Welcome to this session. Today we will tackle an exciting, challenging topic, how to treat severe periodontitis non-surgically. This is addressed to all dental professionals having patients suffering from acute and recurrent chronic periodontitis that basically see that the current therapy are not fulfilling completely patient's expectation, where we see a lot of residual pockets, and yeah, as said, patients that have to come back again and again to get handled. Today, and in general at Regedent, we always develop our therapies based on the standards of treatments. And this is what you can see here, what the European Federation of Periodontology recommends to treat patients with periodontitis. This was published in these S3 guidelines. You see the phases where the patients get first the supragingival instrumentation. In many countries, this is carried out by the dental hygienist. Then, if the pocket depth and the situation is not improving, the patient undergoes the step 2, which is the subgingival instrumentation. There is a reevaluation at this stage. And if at the reevaluation, the dental professional sees that the pocket depth is still equal or superior to 4 millimeters with bleeding on probing, then there would be again an instrumentation of the residual pockets, of the remaining pockets, or a surgery. However, if the patient sees that all their periodontal pockets are less or equal to 4 millimeters without BOP, then these patients will go in supportive periodontal care. So let's look first at what are the limits of today's subgingival instrumentation. This is typically what you would face in your practice. So patients coming with severe periodontitis, with periodontal defects that requires interruption of the inflammation and the regeneration of the hard and soft tissues. What we know from the literature, this is a study from Tomasi in 22. He basically documented that patients with 4 to 5 millimeter pocket depth undergo the subgingival instrumentation at step 2, and after this subgingival instrumentation at the reevaluation, they noticed that still 28% of the patients have residual pockets. These patients undergo then a step 3 reinstrumentation, and there we see that only 11% of these pockets have been closed. You still have 17 pockets, 17% of the pockets open. Situation gets even worse when the pockets are deeper. We see that here patient resolution after step 3 is half-half, meaning that some of the patients would need to have reinstrumentation again with limited impact, or surgery, knowing also all the downside of what this encompasses. So what we are looking at is not just to solve the situation of some sites here and there, but we need obviously to be able to offer the patients a therapy that helps them to step out of the practice without having residual pockets. So it's really helping dental professionals to have a holistic treatment to be able to treat patients more effectively. What we've learned from the raw data of the Romanowskaite study in 2023, we learned from her study that basically in the control group, the patients treated at the step 2 with SRP, with curettes, were first diagnosed with a certain amount of periodontal pockets. So we see here the patient number 1 has roughly 80 periodontal pockets. In the control group, there were 24 patients, all with different amount of pockets. And these patients got subgingival instrumentation. And after the step 2, Dr. Ramanauskaite reevaluated the pockets. And there we can see that this patient number 1 had roughly half of the pockets closed, let's say healed, and half of the pockets still open, residual, needing further treatment. Looking at the patient base in this group, 100% of them needed to have further treatment. All of them had still residual pockets. So this was a 0% success rate. So that's basically what I mentioned before, is that these patients had supragingival treatment, then this subgingival treatment, and all of them have to undergo a step 3. Why is that? Well, we know that there are different factors that we can address. The first one is that subgingival instrumentation is a tremendous challenge. From the literature, we know that around 30% of the biofilm remains subgingivally, meaning that the dental professionals have a real challenge, difficulty to remove all of that. This is perfectly understandable. We know also that there is a periodontal microbiome, and in the Ramanauskaite study from 2024, she documented that when SRP is carried out, we see the evolution of the microbiome in the deep pockets. So if I take, let's say, these 4 prevalent bacteria, we see that this is baseline, the first stack, baseline, baseline. The subgingival instrumentation is carried out. We see that the quantity of bacteria is reduced at 3 months, but at 6 months it goes back to normal. And this pattern is the same for all the biofilm bacteria. We know also that from the literature previously documented. One outlier is this AA bacteria at the beginning. Why does it follow a different trend? Well, one of the reasons is that this AA bacteria is maybe not so prevalent in the biofilm, but more in the granulated tissue. And when standard SRP is carried out, there is basically an activation of this bacterial load in this granulated tissue around the tooth that basically stimulates its growth. This is very commonly the reason why antibiotics are prescribed, to be able to handle this bacteria. After step 3, there is always this dilemma for the patient that still have residual pocket. Do we keep on going with reinstrumentation, or does the patient need a surgery? Obviously, the surgery helps to have a higher pocket closure rate, but it's invasive, it's costly, and we know from the literature that roughly 10% of the patient population really accepts this type of treatment. So having a non-surgical alternative is important. But how can we then help the non-surgical option to be more effective? That's the challenge. We know also that from surgery or from reinstrumentation, there is an increase on the recession. We know that also from the literature that the more we reinstrument, the more the recession is going to increase. So it helps to reduce the pocket depth, but at the expense of the aesthetic aspect, meaning that the recession increases there. So the 3 challenges that we want to address are: 1, the instrumentation without adjuvant does not achieve sufficient decontamination. We want to have a better cleaning rate. Remember this 30% of the biofilm remaining subgingivally? Then we want to affect the microbiome around the teeth. Make sure that at 3 and 6 months, this microbiome is reduced and is less aggressive. And obviously, we need to take into account the risk of recession, and we could also add the financial aspects. So imagine if today you have a patient coming with a situation like that, a deep pocket, bleeding on probing. You would have to offer a solution that is maybe not optimal, where basically he will suffer from a worse aesthetic result, maybe with healthy pocket. But the alternative is this one. is being able to reduce the pocket, improve the clinical attachment, while at least keeping the recession at the same level or maybe improving it. So that's what we see today, is that from the literature, patients come with subgingival instrumentation needs, they undergo the treatment, all of them still have residual pockets, and at this stage, they need to have, again, a re-instrumentation. We know that some of them will be, let's say, with all pockets closed, 38% of the patients, but still an overwhelming 62% might need surgery or re-instrumentation again. So this situation really leaves a lot of patients in a tough corner. What we propose is with the adjunctive treatment to change this paradigm. So typically, this is where a dental practice would introduce clean and seal. In our research, we've shown that when clean and seal is added to the current therapy in step 3, the amount of patients that get their pocket closed is already 54%. You remember before we were having 38%. And still 46% would have residual pockets and maybe need surgery. That's already a win, but for us, this is not enough. I think we can even do better. And this is why it's interesting. The earlier the dental professionals can interrupt the periodontitis, the better for the patient and the better for the dental practice as well. It means that when acute pockets are directly treated with SRP and the clean and seal products, you get already 40% of the patients going straight into supportive periodontal care. Of course, this therapy takes maybe a little bit more time when introduced at step 2, but measure the time that you're saving overall with all these patients needing only one treatment. You still have 58% of the patients with some residual pocket, but there, our literature has showed that these patients have much fewer residual pocket than patients being treated only with SRP. And these patients with less pocket, they need to have instrumentation, but much less than the patients with traditional SRP. So there is also time saving in step 3 with patients with less residual pocket, and many of these patients will get this residual pocket closed. So you can see that 73% of the patients can avoid a surgery or a thorough instrumentation. You still have some patients with few pockets. It's not a magical bullet, this is clear. But there, of course, we see that's a huge difference with the traditional therapies. So clean and seal, what is it? It's first addressed to patients with severe periodontitis, where a first gel is added into the pocket to help cleaning. This is going to attack the biofilm. This is going to dissolve the granulated tissue to make your life easier in the cleaning step. And an easier life in cleaning step means being more effective. Remaining this 30% of biofilm remaining can be reduced to a less critical level. Then it's instrumentation. That's what you do on a daily basis. No change there. And once the site has been cleaned, we need to protect the wound. This is like when our kids are hurting themselves when they fall on the ground. The first thing we do is we clean the wound and then we put a Hansaplast to protect it. This is exactly what this second gel is doing. It's protecting the re-entry of the bacteria along the tooth of the implant. And on the apical side, we've documented it to regenerate hard and soft tissues. We have histomorphometric data showing that we have regenerating cementum and periodontal ligament. And remember, these two are essential to close the pocket for long term. So the first product that helps the cleaning is called Perisolve. It's actually a product combining two two ingredients, sodium hypochlorite, but not the 2% or 6% that are extremely aggressive. It's 0.95%. And in the other syringe, there are amino acids that are mixed with this sodium hypochlorite, reducing it down to 0.5%. This product has an extremely visual effect in your hand. Here you can see how this is mixed, very easy, 10 to 15 times until basically the solution is homogeneous in the transparent syringe. And then this is applied into the pocket. Need to wait a little bit, and it's going to facilitate the mechanical cleaning. We will show all of that in a second. PeriSolve has the specificity to have a very targeted effect. It helps to dissolve granulated tissue, and this is something you will appreciate in your hands. It's extremely visual. But how is that possible? It's magic? No, it's not. What we know is that tissues are here, represented in blue. These are typically gingival tissues. And then in the pocket, we have granulated tissues. When we take normal sodium hypochlorite with a high concentration, this is basically aggressive to any type of tissues. And so this is something we cannot use in such situation. It would hurt the healthy tissues and obviously be counterproductive. What PeriSolve does, it's a low concentration and it has amino acid that basically have no effect on dense tissues with structured collagen fibers. It means that when you apply PeriSolve, it's not going to impact healthy tissues. It's only going to dissolve the granulated tissues. You will be able to take them out with a tweezer. And then on the healthy tissues, no impact. Why is that interesting? It is interesting because it means you can repeat the PeriSolve cleaning until the site is clean. Every patient is different. Some patients have pockets much more, let's say, dirty than others. And so these patients need more cleaning cycles to get to a situation where the pocket is clean. You can see here how granulated tissues are basically taken out from the pocket. This is with the courtesy of Dr. Egle Hermann-Auskeiter. Very easy to take out, very fun. And then once the site is clean, the second gel called Hyadent BG is going to have its protective and regenerative effect. It's a special gel, combination of different types of hyaluronic acid. Cross-linked hyaluronic acid that will have an effect on hard tissues, remember the periodontal ligament, the cementum, and natural or linear hyaluronic acid that will have an effect rather on soft tissues and resorb rather rapidly. This gel is of a high molecular weight, non-animal origin, and it will have an effect between 4 to 6 weeks. The needles are not part of the box, they need to be added separately, and the ampulla fit your standard syringe in your practice. Hyadent is going to have an immediate effect by protecting the wound. It's going to fill up the pocket and basically work like a shield against the bacteria re-entry into this pocket. It's going to speed the wound closure. This is what we documented. For example, in Ildrim et al. In 2017 showed that we can close a wound twice faster when this product is used. It's anti-inflammatory, meaning that it's going to speed the oral wound healing and obviously improve a little bit the comfort of the patient. And maybe the most important is the last point, is going to have this effect on hard tissues. That's the true core closure of the pocket. The properties of Hyadent BG, the first thing is it's going to be hydrophilic. It attracts the blood, stabilizes the coagulum where we need it. So it works with the fluids. No need to prep the site with EDTA or a dry pocket. No, Hyadent BG wants blood to be able to attract it where it's needed. Then hydrogen BG, as said, is made out of two types of hyaluronic acid. The linear one, that's basically a simple chain like this one, is going to resorb rather rapidly, but have a big impact on soft tissues. And then we have the cross-linked hyaluronic acid. You can visualize it like that, where the chains are glued together, and the bigger the matrix, the more time the body will need to resorb it. And our in vitro data showed that this takes 4 to 6 weeks to be resolved. That's the time needed to have an impact on hard tissues. Hyaluronic acid is known to be naturally present in our body. This is documented close to a century. We know that hyaluronic acid is involved in cellular migration, cellular adhesion. We have a study from Müller et al. In 2017 showing that when you apply hyaluronic acid and even cross-linked hyaluronic acid on dentin, you have more periodontal ligament cells that will adhere there. HA is also involved into cellular proliferation and in some of the differentiation processes. As mentioned, it's bacteriostatic, it's a shield against oral bacteria, and it's anti-inflammatory. Very often when we hear hyaluronic acid, we think dermal fillers, but hyaluronic acid is a family of material. Dermal fillers are hyaluronic acid very cross-linked, and they're cross-linked so that they can stay in situ 1 year or 2. They have a volumizing effect, but because of the high level of cross-linking, they have a very minor or no effect on regenerating tissues. This is where, on the other extent, you have native or linear hyaluronic acid that's made out of these simple chains that have a big impact on soft tissues, but they resorb very rapidly, 48 hours, so they won't have an impact on hard tissues. That's where hydrogen BG gets the best of both worlds. It has an impact on soft tissues and on hard tissues through the slightly cross-linked HA. This is a visualization of one of the property with the courtesy of Professor Andrea Piloni, who's one of the father of the hyaluronic acid used in dentistry. He did his research already at the end of the 80s and showed its very valuable properties in periodontal treatments. Here he has treated a coronary advanced flap. He opened the flap, removed the granulated tissue, and there he applied hydrogen BG. And the interesting thing is this one. You can see that the blood is attracted throughout the gel and the coagulum is stabilized here on the root surface. This is the first step of the oral wound healing. Clean and seal in action in dermatology here with the courtesy of Professor Anton Friedman. For the story, this was a necrotic wound that one of his assistants had on the leg due to a burn. This was 6 months old, couldn't heal. And when he saw that, with the approval of the dermatologist, he decided to apply clean and seal. You can see that he applies first Perisolve. He waits that Perisolve acts. The product needs to stay at least 1 minute to dissolve the granulated tissue. He removes them very gently with a tweezer, repeats that until the wound is clean. And once the wound is clean, like we can see here, the second gel that will help to protect and regenerate the tissues, higher than BG, is applied directly. So you see it's extremely easy to apply, it's viscous, it's going to adhere to the surface, very easy to use. And you see here the healing within some weeks. So how do we use clean and seal? Extremely straightforward. So you would diagnose your patient, realize that they have deep pockets. You would apply the first gel Perisolve in the deep pockets. You can fill up all the pockets. If it stays more than 1 minute, there's no problem. And then you would go to, for example, one of the distal pockets. After 1 minute, you start to do the instrumentation. You will remove the granulated tissue very easily. You will scratch away the biofilm. And then you rinse with some saline solution. This is the moment of truth. At that point in time, you will see what comes out from the pocket. There will be maybe a lot of blood. There will be a lot of granulated tissue. As long as you have this material coming out, you need to repeat the cycle of applying Perisolve, instrumenting, and rinsing. These cycles until it's clean. What we know is that for periodontal treatment, we need to count 2 to 3 cycles to really have the pockets clean. In case of peri-implant infection, this requires many more cycles, 5, 6, 7, 8, due to the implant topography. Another question that we often get is, yes, curettes are good, but also use ultrasonics. Very well. Here, from our customer base, we recommend that you use ultrasonics to remove the bulk of the biofilm, to open the pockets, and then you use Perisolve, you wait, and you do the instrumentation with the curette. One of the reasons is that ultrasonics have a constant water flow, and that will wash away what's in the pocket. So you will miss this moment of truth where everything comes out at once. So you repeat this treatment with the curette, you can go deep into the pocket, and you finish the cleaning with this curette and Perisolve. A very important thing is do not use chlorhexidine in the subgingival pocket. Chlorhexidine is inhibiting the cellular adhesion, and so it has a counterproductive effect on the regeneration. Once the site is clean, you just fill it up with the second gel, Hyaden BG, and there make sure to fill up all the treated sites. So not just the deep pockets, but also shallow pockets to limit the risk of simply microbial cross-contamination. And this will protect the wound and stimulate the hard and soft tissue regeneration. So let's look at the evidence in step 2 of clean and seal, subgingival treatment. Here we have the key study from Dr. Egle Ramanauskaite in Lithuania that worked with the team of Professor Anton Sculian in Bern. They did this randomized controlled trial where they treated 48 patients, one group just with curettes and the other group with curettes and clean and seal. What they could document is the following. First, on the clinical parameters, we can see that on the pocket depth, after the first treatment, both groups have a tremendous reduction of the pocket depth. But at 3 months and 6 months, you see that the result remains rather stable with the SRP group. Whereas where clean and seal was used with the curettes, we see that not only the pocket depth is reduced at 3 months, but it keeps on going down at 6 months. The results are coherent also when we look at the clinical attachment loss and the bleeding on probing. Maybe this latter is also extremely interesting to constantly observe because that's the early indicator of maybe a relapse if there is an inflammation. But here we see that there is a negative trend in reducing the BOP. One key insight of this study is that the effect of the clean and seal is even more important on deep pockets, as you can see there. What she measured, and that's what you've seen earlier, is that these are the patients with SRP. All of them still have residual pockets. But the patients treated SRP with clean and seal, 42% of them had no more pockets. And you see, these are the ones where it's only a green stack, no residual pockets anymore. Few of them still have residual pockets, but very few pockets. meaning that for step 3, there is less time needed to re-instrument these few pockets. You can see here, day and night. This has obviously a huge impact on the patient satisfaction, but also on the patient flow within the practice. Let me share with you a case with Dr. Rico Young from Germany. So we see here the period chart is a great indicator to see how a patient is doing. There we see that this is a patient with very deep pockets, bleeding on probing, complicated situation. We see on the X-ray also defects there. So at the baseline, Dr. Young is probing. Diagnostic shows that it's severe periodontitis. So he applied Perisolve, did instrumentation, waited, repeated the cycles until it's clean. And then at the end, you can see here, he's applying cross-linked hyaluronic acid, higher than BG, into the pockets, and it leaves it there. At 3 months, we see that there is no inflammation. The periodontal tissues are tight around the tooth. There are overall improved clinical parameters. And that says it all. You can see that the period chart at 7 months shows no more signs of deep pockets and very few BOP remaining. 3.5 years later, situation is stable. Let's look at patients having already residual pockets and coming at step 3. So here we have the study from Dr. Laura Beignet, who basically applied clean and seal to the control group and clean and seal to the test group, and the SRP was a control group. Here, to make it short, you can just see that the group that was treated with clean and seal suffers from less gingival recession over time than the control group. The clinical attachment loss is also lower for the test group. And there, similarly to the Ramanauskaite study, you can see that even though these are residual pockets, the deep pockets get closed. Here is a case from Dr. Hilliard Ramanauskaite, where she diagnosed severe periodontitis with, you see, a very, very deep pocket, bleeding on probing. We can see the defect very nicely there. She's basically preparing Perisolve by mixing the components, applying Perisolve, waiting at least 1 minute, and then she did subgingival reinstrumentation with mini Gracie curettes. She did that 2 cycles, 2 times, to get it really cleaned. And then she filled up the pocket with higher than BG. You can see that the blood is basically going through the gel. That's this hydrophilic aspect, the blood clot stabilization. And you see the improvement, and the situation is stable. 4 mm pocket depth, no BOP at 12 months. It's very similar to what she had already 3 months. So it's a very fast impact that is lasting. And we see on the radio the remineralization of the hard tissues. So at Regedent, we carried out the research in a very structured way. It was clear at the foundation of the company in 2013 that periodontitis and periodontal defect require some help to get cleaned and to regenerate the tissues. And what the team did is sequential research, looking at different cleaning agents and regenerative material, looking first in vitro how these materials behave. And here we see for Hayden BG, there was some in vitro study looking at the cellular adhesion on dentin. Then Asparova looked at how different types of hyaluronic acid have an impact on cellular proliferation. And then there were in vivo study on dogs to see how in a biologic settings hyaluronic acid interacts with the soft and hard cells, and this for the first time could document the impact of hyaluronic acid, cross-linked hyaluronic acid on heart cell regeneration, to then go for studies on patients. Same for Perisolve. And during the COVID, it was clear that Perisolve and HidenBG were the best products to be able to achieve the goal we had, the ambition we had for Clean and Seal, and that's where the first combined studies were started with research on residual pockets, on acute pockets, also some data to document the biologic effect in vivo, and also some in vitro data to understand how this solution helps to interact or contributes to interact against the development of biofilm, for example. Here we have a fascinating study, again from Eglita Manauskaite, that looked at the microbiome around the tooth in the pockets after treatment. In the control group, where patients were treated only with curettes, as I mentioned before, we see this V pattern where there's a mechanical instrumentation. It reduces a little bit the bacterial load, but then it comes back to normal. With the AA bacteria present mostly in granulated tissue, we see actually a stimulation of this bacteria. What we notice with Clean and Seal is tremendous. The AA, where we have therapy that helps to remove more effectively granulated tissue, we can reduce significantly the amount of granulated tissue with this bacteria. This is obviously opening the question to, do we need, to the same extent, antibiotics to control this bacteria? This is still an open topic for research. We see on the bacteria mostly present in the biofilm that there is a tremendous reduction of the bacterial load, and that it's all on top of it lasting or even keeping on reducing. And there the specialists have the idea that the cleaning and the sealing work together. An effective cleaning has an impact on reducing the bacterial load at 3 months. But then, since HidenBG helps to regenerate cementum and periodontal ligament, it contributes to close the pocket, leaving fewer sites, fewer locations for the bacteria, for the gram-negatives to repopulate. Then, hence, this effect that keeps on improving. We see the clinical parameters being very consistent with what we saw on the microbiome, with an improvement for the test group lasting over time. Here is this fascinating in vivo study from Yoshinori Shirakata, who did that with the team of Anton Sculian in Bern. He basically induced severe periodontitis to dogs and had 2 groups. One group where the dogs were only treated with curettes, and one group where it was Clean and Seal with curettes. And what you can see here is fascinating. You can see that the group treated with Clean and Seal had, at the time of the histology, a regeneration of the cementum. This is this thin line that you can observe there. You can see that the periodontal ligament has been regenerated partly, and qualitatively you can observe an orthogonal cellular structure with the sharper fibers adhering to the cementum. So this is very close to a regeneratio ad integrum. In the control group that was only treated with SRP, this is a reconstruction. We don't identify any cementum. The periodontal ligament grew, but with a cellular structure that is parallel to the tooth and with little new bone regeneration. And on the quantitative side, that's where it talks for itself. We see that the delta between the control group and the test group in terms of pocket depth is extremely big, is statistically significant. The clinical attachment has been also improved a lot when using Clean and Seal. and the BOP has been reduced to a minimum. So Clean and Seal helps really to tackle non-surgically these challenging cases everywhere today. So today the question you have to ask your patients is, would you like to have a treatment where there is a risk of having open pockets, where you would have to come back to the practice to be retreated again and again, and you might have to consider surgery, knowing that the gingival recession may increase? Or would you be interested to have a treatment that is more innovative, that helps 42% of the patients to have a success after only one session, and 73% of the patients can even avoid surgery, and on top of it, less gingival recession? That's the question to ask to your patient. Thank you very much. For any questions, feel free to contact us at Regedent. Happy to answer your questions and your requests. Bye-bye.